Hi, everyone. I am Steve Baskin. I am here to talk on migraine and mental health. And it's really an honor to talk to you guys. I'm going to do a couple different things. I'm going to introduce myself and talk a little bit about my experiences and give a little bit of an introduction and talk a little bit about this partnership the American Migraine Foundation and Biohaven have had in putting this pretty intensive survey together looking at migraine and mental health. So I'll give you a few of the high points of that survey, and then I'm going to have a short slide presentation talking about migraine and mental health, a variety of the psychiatric diagnoses, what they mean, how they mean, how they make sense to people with migraine, and then open it up for questions. So anyway, just my background, I'm a clinical psychologist. I've been practicing for many years. And I've seen headache patients for a very long time. I'm also a medical psychologist, which means I did a 2-year fellowship in clinical psychopharmacology. So I do two kinds of things. I'm at a headache center in Stamford, Connecticut, the New England Center for Headache and Neurology. And I also am in outside New Orleans, Louisiana, in a very underserved parish as one of the few mental health prescribers. So as a medical psychologist, there's some states I can prescribe medication in. So I see many patients in this Louisiana office who are migraine sufferers with a variety of behavioral and psychiatric issues. Just, a quick start here. I got interested in headache initially. I was training at a large Midwestern medical center, and I was on the psychiatric consult service, and neurology would send us patients that say, somebody has migraine, is it functional? And that's a nice way of saying, is this a psychiatric problem? And nobody knew anything about migraine, including the neurologist. So we would go see this patient on the psychiatric consult team, and I would say to myself, my God, this woman looks really sick, and she looks terrible, and she's telling about all these headaches he had, but no, this is not a psychiatric illness. It's clearly a problem. So I decided I was going to learn something about migraine since nobody else seemed to know much about it. This was many, many years ago, and I became fascinated in the idea that one can have these intermittent headaches. Why does someone have migraine? Why would you have sensitivity to light and sound and nausea and vomiting and an aura sometimes and sometimes not? And it was just fascinating to me. And then also the interplay between other disorders and psychiatric issues and what that all means. So I've been fascinated for years with migraine and tried to make a contribution both clinically and research-wise and really learning a lot about it. And it's an amazing thing that these are separate diseases that psychiatric illnesses as well as migraine, but they certainly share some mechanisms and they share some genetics, but they're very different. So migraine is a neurologic disorder, and there's depression and anxiety, and they do coexist, but they're separate disorders, and they need treatment for both of them. And I would have to say that over the years, I would say that migraine sufferers are amongst the most resilient people I have ever met. I am really proud to have worked with migraine patients over the years because they showed me how to kind of manage aspects of my life that sometimes felt out of control, and I felt helpless because they were in that state very, very frequently. So there's a partnership between the American Migraine Foundation and Biohaven in order to look at some of these psychiatric issues, and we had 1,100 patients we surveyed and 300 docs. So we looked at patient responses and physician responses, and they were very similar to the patients that I see in a tertiary care center. So I think on the average, patients had 15 headache days a month, and they had 10 migraine days a month. So these are people right at the chronic migraine, high frequency episodic migraine level, but with 10 migraine days a month, a patient population that was fairly significant. And on their self-report, almost 80% had an anxiety disorder, over 60% had depression, 40% had post-traumatic stress disorder. If you looked at them being diagnosed with that by a physician, it was little bit less, 57% had anxiety, 50% depression, 20% PTSD. But it was really a fairly significant headache population with psychiatric issues. And both patients and physicians in this survey realized that migraine and mental health really impacted each other, that there was really a vicious cycle between migraine, mental health issues, and how they increased and decreased, over the lifespan. And the thing that patients seemed to be the most concerned and worried about were the uncertainty and the unpredictability as a major stressor, that this disorder had this unpredictable, intermittent, severe quality that they didn't know was happening. And patients worried about sharing their headache, their mental health burden with headache providers, because they were fear of kind of a compound stigma, that you have the migraine stigma and now you have the mental health stigma. And, there were many, many findings we had, but one of them that was fairly significant is that physicians underestimated the number of patients who suffered from mood and anxiety disorders. So the patient's sense of their suffering was greater than the physician perception of their suffering. So that's just a little bit about me, what I've done over the years, how I got interested in all of this, and a little bit about this survey that shows really a significant mental health burden as well as a migraine burden that is really significant. So if we can go to my slides, that would be great. And we'll go about 15 minutes of that. And then we will, I'll open it up for any questions you guys have, and feel free to ask away. So can I have the next slide, please? So let's just start with a basic idea. So we know a lot about migraine, but migraine attacks are characterized by kind of a hypersensitivity, a sensitization, and an alteration of multiple systems within the brain and other parts of the central nervous system, as well as the peripheral nervous system. And they can be activated by many, many triggers, behavioral triggers, many physiologic stressors, and certainly can be activated by psychiatric issues. So these are two separate kinds of disease states: the neurologic disease state, migraine, a variety of psychiatric diseases, but they can activate each other and are comorbid. Can I have the next slide, please? So one of the things that I do when I first see a patient, and you look at the survey, these patients have lots of headaches and lots of migraine. And I want to know, other than making a diagnosis and all the important things you do in an initial session with the patient, I really want to know, are they having risk factors that are going to progress them to chronic migraine, more than 15 days of headache a month, more than a significant number of those days as migraine does. So when you look at the comorbidities, there's some psychiatric issues: depression, anxiety, sleep disorder are all psychiatric issues that can progress migraine into a more frequent and disabling disorder. Also, stressful life events, including childhood maltreatment, and we'll see some of the data on emotional abuse in migraine patients and how that might chronify migraine. A variety of other ones, as you can see, but a very important one here, as you can see in the lower right, is poor treatment efficacy and medication overuse. And many, many migraine sufferers do not get effective treatment. And if you have a psychiatric issue, it's very easy for somebody who's not all that knowledgeable in migraine to say, well, this is psychiatric, this is why the person isn't doing well. But you need to be an advocate for yourself and realize that poor treatment efficacy is a big reason that this progresses. And I'll show you later data that shows that migraine sufferers with psychiatric issues, if treated well for migraine, even with psychiatric issues, improve almost at the same rate as migraine sufferers without psychiatric issues. And the same thing with medication overuse. When your headaches are out of control, it's easy to overuse medications. Some migraine sufferers, in particular with anxiety disorders, have a lot of fear, and they overestimate the probability of migraine. They feel something, they say, oh my God, I'm getting a migraine. They take medication kind of as a preemptive strike. Those patients, the medication overuse might be related to their anxiety. And there are some studies to show that patients with migraine and medication overuse headache typically had their psychiatric issues before the medication overuse. They might have had anxiety or depression beforehand. As their migraine got worse, they had a tendency to overuse medication. Can I have the next slide, please? Well, there's a lot of stress-related factors. You hear a lot about stress and migraine, and people talk about stress in all kinds of different ways. But the biggest stressor in migraine, you have high levels of daily stress that may transform to chronic. But the biggest stressor in migraine, and unfortunately these slides are an earlier iteration, but the biggest stressor in migraine is having migraine. So that the way this slide's supposed to read is the first thing is that if you have migraine, you have a much higher, the unpredictability of having migraine is probably the biggest stressor in migraine. But high levels of daily stress may transform to chronic if you're having lots of life changes. And the most important one is the uncertainty and threat of having migraine. You can have a letdown post-stress. Richard Lipton has shown that that's a precipitant to migraine. Stress, 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 stop, migraine. It's greater in patients. So stress has a much greater impact if people have mood or anxiety, issues. Trauma is associated with more disabling headaches and more likely to transform into a more chronic form. And most importantly, it's really helpful to learn techniques to reduce kind of this emergency, this internal action response that activates our nervous system. Can I have the next slide, please? So this is just a slide showing how all the issues that we've talked about with people with migraine who do have psychiatric, issues, that they do chronify and they do are more prone to medication overuse. But if you see in the middle one, it says poor drug tolerance, and that's really from the older medicines. And I'm going to show you some data in a minute showing that that's probably not true. We did a study, with rimegepant, showing that it was well tolerated in people with depression, and it was also well tolerated with people who were on antidepressants. And we presented that at the American Headache Society meeting a couple of years ago. But you can just see that, you can read it across. So there's a burden to having migraine plus psychiatric illness. Can we have the next slide, please? So if you look at people with migraine, what their psychiatric comorbidities are, well, you can see the numbers. In depression, if you have chronic migraine, it's close to 50%. If you have episodic migraine, it's about 20%. Anxiety is way over 50% with chronic and a little bit lower. Anxiety disorders are more prevalent in migraine than mood disorders, but you can see, but bipolar disorder, about 8 to 9%. Panic disorder is relatively high comorbidity with migraine, and post-traumatic stress disorder in tertiary care is very high. In secondary care, primary care, or in a population, it's a lot lower. But if you're in a tertiary care headache center, people with PTSD are fairly high. Chronic migraine is greater than episodic. So the more frequent migraine is, the greater the probability of having a psychiatric comorbid problem. Interestingly, this is kind of fascinating to me, it's greater in migraine with aura than migraine without aura. But that's only for bipolar disorder, depression, and panic disorder. Generalized anxiety disorder, which is a common anxiety disorder, is probably similar in both. But on the whole, psychiatric comorbidities seem to be more common in migraine with aura. They're certainly more common as they are more chronic, and they're certainly more common in treated patients than in the migraine population in the community. Next slide, please. If you look at bipolar disorder, panic disorder, OCD, common psychiatric disorders, it's kind of fascinating. If you look at the left side, it's people with the psychiatric disorder. So you look at bipolar disorder, and 30% of the people with bipolar disorder have migraine. It's a huge increase. And mostly that's bipolar 2, which is the manic episodes are shorter and not as dramatic. But you can see panic disorder, it's more frequent. Obsessive compulsive disorder has migraine more frequent. And then if you turn it the other way, people with migraine have a higher risk for bipolar disorder, for panic disorder, as well as for obsessive compulsive disorder. Can I have the next slide, please? This is just a Brazilian community health study, and if you look at it, it's interesting. As migraine frequency goes up, the odds ratio of having depression go up. So this is migraine and major depressive disorder, and if you see, if you have less than a migraine a month, you still have a 2-fold greater chance than people who have no migraine to have depression. But if you have daily headache, it's almost 7-fold greater. It's like 6.5-fold greater. So as migraine increases in frequency, major depressive disorder as a comorbid illness also increases in frequency. Next slide, please. These are just the symptoms of depression. You need to have on the bottom, you need to have at least one of either loss of interest or pleasure, or decreased mood, sadness, and then some of these other things. You need a total of 5 symptoms to get it, and you need to have it every day. I mean, most of every day for a consecutive 2-week period of time. So that's how one gets a diagnosis of major depression. Next slide, please. This is just a little screener, and you can see the first 2 questions on that screener predict a tremendous amount of the variance. So you have little interest or pleasure in doing things in the first one, or feeling down, depressed, or hopeless in the second one. And if you just, click it again, you will see the numbers. If you have the next slide, that a cut score has a pretty good amount of sensitivity and specificity, hard to say that, for major depression. So, those 2 questions are very helpful in diagnosing depression and being aware of it. Can I have the next slide, please? Thanks. Suicidality, not to make people afraid of this, but migraine in and of itself has associated with a small increased risk for suicide attempts. But that's in particular in patients with both comorbid depression and anxiety. Anxiety disorders added to mood disorders really create more disability. So if you're depressed and you have a lot of agitation and irritability and restlessness and worry, it makes it a much more profound problem. And there's a lot of other things, obviously, that are, with increased risk for suicide. But it is important to be aware of suicidality. Any brain disorder, be it migraine or depression, has a risk for a little bit of an increased risk for suicidality. Next slide, please. So why do we see these psychiatric disorders or migraine having shared mechanisms? Well, there's been a lot of genetic studies to show that they share some bits and pieces of genetics, of which it's very hard to see a coherent thing. But there are some shared genetics, but also some shared childhood adverse events and ongoing or recent stressors are part of it. But there's a lot of people looking at this and a lot of hypotheses without knowing for sure. Serotonin neurotransmission, the serotonin transporter, and also the D2 dopamine receptors are probably dysregulated in both depression and anxiety disorders, as well as migraine. And also you see impaired regulation of the stress response, the hypothalamic pituitary axis in both disorders, that it takes less to trigger a response. And then migraine and depression, kind of interestingly, that a lot of people don't think about, but they have monthly and lifelong fluctuations in ovarian hormones affect them. So you can have a drop in mood around menses. You can have postpartum depression. You can have a tremendous increase in migraine around menses. So these lifelong fluctuations of ovarian hormones, suggest why migraine is more common in women and why depression is more common in women. And it's kind of fascinating because all these neurotransmitters we talked about, as well as glutamate and GABA and all these either excitatory or inhibitory brain chemicals, are affected by ovarian hormones, and they do affect mood, and they affect anxiety, and they affect migraine. And also, a lot of people don't realize that sensitization. So if you have a lot, the reason to treat migraine aggressively is if you have attack after attack after attack, you'll develop kind of central sensitization. Your brain will be sensitized, and it'll transform migraine into a more chronic condition. See the same thing with depression. If you have an episode of depression that's not treated well or aggressively, people will have more episodes, and then eventually they have kind of, what they call a persistent depressive disorder. And this is probably related to some brainstem dysregulation, but you do see the sensitization process in both migraine as well as depression. Can I have the next slide, please? Now, you see the same thing with bipolar, in bipolar disorder, and an increased, a significant comorbidity between bipolar disorder and migraine. And just two things to know: there's bipolar 1, bipolar 2, and what they call cyclothymia. But mania is the defining feature of each, and it's differentiated by the severity and the duration. So for actual mania, you need a week, and usually intense elation or irritability, and you have sometimes risky behaviors. People are talking fast. They have a decreased need for sleep, and it has significant impairment. For hypomania, it's nowhere near as dramatic. It's less intense. The symptoms have to last at least 4 days, and there's it has to have a clear change in functioning, but that's tougher to diagnose. So one of the problems we have in looking at psychiatric issues of people with depression, if they have not responded well to antidepressants, sometimes they have little episodes of hypomania which require different treatment. And bipolar 2, which is bipolar disorder but hypomania, not mania, is very comorbid with migraine, and there's a huge relationship. So it is kind of interesting in terms of that hyperexcitability phenomena. Next slide, please. Now, the anxiety disorders, what are the symptoms common to across all the anxiety? I can't go through all of them, but the symptoms that are common are danger-related cognitions, fear, worry, physical symptoms like feeling on edge, tired, your concentration's off, your sleep is off, muscle tension. Some of those are very similar to symptoms in migraine. In almost every anxiety disorder, you have an avoidance behavior, and some are very subtle. You avoid the stressor, you avoid, so if you have social anxiety, you avoid social events or public speaking. If you have panic disorder, you might avoid the place you initially had a panic attack, or you avoid doing anything that makes you have some internal sensation. And it's very important in migraine because in anxiety disorders, people will overestimate the problem of danger, and migraine fits right in there. And they're also very sensitive to medication side effects and internal physical sensations, as we'll see in a second. Next slide, please. So these are just some sample anxiety questions that I ask people. How do you respond to early warning signals of migraine? What do you do? And some of our treatments involve writing down a coping skill plan. What do you do before you have an attack, early sign of an attack? If it's at a critical moment, how do you handle it afterwards? How do you review it? Do you have a hard time controlling worry? Have you ever had a panic or anxiety attack? And you can see what kind of things do you avoid because of your migraine? Have you changed your behavior because you're afraid of having headaches? And one of the things that I always ask is, were you an anxious child? Because if you look at the data and migraine and psychiatric disorders, typically, it's variable, but a very constant one that you see is anxiety as a child, sometimes school phobia, migraine usually around first menstrual period in women, a little younger in boys, a depressive episode, maybe in their 20s, and then if they develop chronic migraine, that happens later on. And so I ask people, were you an anxious child? I like to get a developmental longitudinal history. Can I have the next slide, please? Generalized anxiety disorder, I mean, you can read it, it's mostly worry. People have a hard time controlling worry, and it's associated with other symptoms, as you can see on the right. But the essence of generalized anxiety is somebody that worries, 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 and cannot control it. Next slide, please. So if you look at it, this is just the first two, the last two are what I showed you before. The first two, it's a good way to diagnose this. Over the last 2 weeks, have you been bothered by feeling nervous, anxious, or on edge, not being able to, to stop or control worrying? But just to be aware, in depression, you need 2 weeks. Generalized anxiety disorder, you need 6 months of this. So this is a much more persistent, long-term thing. You can't just be worried for 2 weeks. It needs to be at least 6 months of this kind of persistent worry. Next slide, please. These are some questions for panic disorder, asking people panic screening questions. Have you had a sudden rush of intense fear or discomfort? Does it come out of the blue for no apparent reason? How long does it last? At its peak level? And how fearful have you been of having another one? You can't have a diagnosis of panic disorder without having a fear of another panic attack. And I'm going to show you in a second why this is important in migraine. Just the model for panic disorder is an interesting model for migraine as well. Can I have the next slide, please? These are just the list of symptoms you can have in panic disorder, and the most significant one is at the bottom right, this fear of losing control or going crazy, a feeling of being out of control. Sometimes people, their heart's pounding, they think they're going to have a heart attack. There's many symptoms of it, but my experience, the important one is, oh my God, I don't know what to do. I can't tolerate this. I feel like I'm losing control. It's not, a lot of times it's not the individual symptom that leads to the panic. It is in the first panic attack, but not later on. Can I have the next slide, please? This is a cognitive behavioral model of panic, and I show this because it's very interesting, when you think about anxiety disorders and migraine. So if you look at the upper right, like migraine, there's a variety of biological, genetics and childhood maltreatment and stress that predispose one to developing panic disorder, just like predispose one to develop migraine. But in panic, people have two things. It's called high interoceptive awareness. They're very aware of internal body sensations. They notice them. And they also have high anxiety sensitivities. They evaluate them as dangerous. So they notice a change in their body and they go, oh my God, this is going to kill me, or I'm going to get a panic attack. So out of the blue, people get a panic attack, and then they go, oh my God, what is this? I might die, I might pass out. And they begin very vigilant to those symptoms, like, my heart's beating a little bit, I hope I'm not going to have a panic attack. So they have increased anxiety and fear, and they get this conditioned fear of these internal sensations. And people with frequent migraine with anxiety have very similar phenomena that, they feel something in their head. They go, oh my God, am I going to get a migraine? I have 5 things to do today. I have to pick the kids up here. We're going away. And they notice they have high interoceptive awareness. They notice the sensation they associate with migraine. They get anxious about it. And, they start to catastrophize, and it builds and it builds. Next slide, please. This is just looking at how complex. So for me, somebody has episodic migraine, they have depression or anxiety on its own, relatively simple to treat. Sometimes complicated, but fairly simple. But as their migraine frequency goes up, they have a mood disorder plus an anxiety disorder, it gets a little bit harder. And then it gets complicated when you have an anxiety disorder and a history of trauma and depression, and headache becomes chronic, and then your headache is so frequent, you start to take medication on a frequent basis, and then it becomes more complex and tough to treat. Next slide, please. Now, these are just a couple of slides to end with. There are two studies showing that on these new monoclonal antibodies, and there's a galcanezumab study with episodic migraine, and a medical history of anxiety or depression did not seem to interfere with that response. And a chronic migraine study, there was patients with moderate to severe depression. They showed significant reduction of migraine days as well as mood improvement on fremanezumab. So there's two monoclonal studies that show that even with psychiatric comorbidities, you can do pretty well. And at one of the studies, your mood actually improved. Next slide. There's a couple of other studies that have shown that. Can I have the earlier one? Yeah. You know, so prior to preventive treatment in this Heckman study in pain, these patients had psych diagnosis, more frequent, more disabling headaches, poor quality of life, and the rates of improvement were comparable across the four groups, which is really contrary to conventional wisdom. With psychiatric comorbidity, you still responded to treatment. And the next slide is Singh and Holroyd, a more recent study showing actually larger reductions in migraine days in the patients with comorbid mood or anxiety disorder. So that might have been a statistical anomaly a little bit, because they had, they started out worse, but it still showed that they had a reasonable response to treatment, even with mood and anxiety disorders. Last slide, please. So what do we do across disorders? Some basic stuff that I do that I think is important, just to, I try to get people to exercise more and increase pleasurable activities. I think it's very important for people to learn applied relaxation and diaphragmatic breathing. I think it really tones the system, turns the volume down a little bit. It helps migraine as well as psychiatric issues. We do a lot of cognitive behavioral treatment for insomnia and try to regulate biologic rhythms. Migraine and bipolar disorder in particular, but many other psych disorders, it is really helpful to eat at the same time, go to bed at the same time, sleep well, and many behavioral treatments to help with that. And we do a lot of, cognitive behavioral therapy for mood and anxiety, try to get people to reward themselves and to decrease their self-criticism, counteract catastrophizing and negative thinking, make people feel that they can control their headache, control their emotional distress around their headache. And a lot of mindfulness strategies, so you can change your relationship with your internal sensations, that you have kind of a non-judgmental awareness of yourself and manage it better. And we also use, treatment, pharmacologic treatments for psychiatric illness, SSRIs, SNRIs, other antidepressants, mood stabilizers when needed. So I'm going to open it up for questions. So I have to. That's a great one. A question that the only time I get depressed is during the migraine or prodrome. Is this still depression or a symptom of migraine? It's a symptom of migraine. Remember, prodromes, something that heralds migraine, either has a hyperexcitability of the nervous system, which you can see with an aura, or a hypoexcitability of the nervous system. So some people feel leaden, tired, down in the dumps. The good news is that if it's a prodrome for migraine, migraine is coming, you can prepare for it, but it is a common prodrome. Any questions are, let's see here. Oh, here's one. So in generalized anxiety, I'm just going to read these, and if I don't know the answer, I'm out there in no man's land, and no person's land, sorry. When general anxiety disorder develops after suffering from chronic migraine for 10 years, is it helpful to find a therapist who specializes in chronic illness, even though there are two separate disease processes that are intertwined? Really good question. I think it's important to see a therapist who treats generalized anxiety disorder and knows like cognitive behavior therapy for, a variety of therapies are fairly specific for generalized anxiety disorder. And I think it's helpful to get really adequate treatment, but it's also very adequate to get treatment for your headache. The biggest problem that I see in some of these things is that patients have to advocate for themselves. They have to say, you know what, I need adequate treatment for my migraine. We know now that if you treat migraine adequately, drug tolerance is not a problem as it was before, and it might help some of my mood and anxiety symptoms if my migraine is under better control. But I also need to see somebody cognizant of migraine, but also who can treat the psychiatric disorder. Headache centers sometimes have people, psychologists, some of them have psychiatrists, social workers that are knowledgeable in both, but it's sometimes hard to find. Let's see what I got here. Anything else here? Does treating comorbid mood or anxiety disorders help with migraine? There's been a couple of studies that show that it helps. There was a study done that showed that psychological treatment for depression also help with migraine. There's not a lot of studies, the antidepressant studies, the SSRI studies were not particularly helpful for migraine alone. There are not a lot of studies where, we see people with depression and migraine. We're trying to do some studies now and take a look at some of the older data. But I think for your own well-being, it's important to treat both of them. And I do think my experience personally is that yes, treating both is helpful for migraine as well, but it doesn't necessarily have to be. I've had people whose mood has gotten remarkably better and their migraine not as much improvement. Thoughts on ketamine for mood and migraine? Interesting. Ketamine is being used for, it's approved now for treatment-resistant depression, and some people use it for chronic pain. We've had some experience, we've used it for people with chronic migraine who have failed many other treatments, or we have failed treating them in many other treatments, and they haven't done very well with mixed results. Some surprisingly good results. I do think it is helpful for depression, but it's in its early stages, and I would not go to. I would really make sure that you have both a headache specialist, and if you have depression as well, a really knowledgeable psychiatrist or psychologist who's on board. Let's see what this is here. I am following the pattern that you identified earlier, where I began in my teens, eventually became chronic, and now in Emgality, only getting 3 to 5 monthly. Would menopause possibly be the end of this journey? Hopefully, yes. If you look at the epidemiology, as women enter menopause, their frequency of migraine goes down. The only catch in that is there's a subset of women right at the start of menopause that have really kind of an increase. So I've had a lot of women patients say, I thought when I entered menopause, I would get better. I've actually gotten worse. And some of them will get worse for a brief period of time and then get improved. So the epidemiology does show that as you get older, after your ovarian hormones are not circulating the way they were, the frequency of migraine most likely will improve. Why does childhood maltreatment predispose people to migraines? Well, I don't know if we know the why in it. We just know that there seems to be a relationship. I mean, childhood maltreatment, there's a lot of data now on trauma And it started out with post-traumatic stress disorder. Some of it was combat trauma, horrible assaults, rape, things like that. But now we're noticing that, people that had very difficult childhoods, mostly emotional abuse, it seems to have some kind of a memory in the body, and they seem to be more prone to psychiatric problems as they get older. And if they probably have a biology for migraine, they might be more prone to having an increased frequency of that. So I don't think we know why, but it probably has a lot to do with the wiring of the HPA axis and the sense of threat. My daughter's post-migraine usually includes some manic behavior with increased energy and sleeplessness. She is 32 and has chronic severe migraines. Is this normal? Well, I'm not sure. It's hard to weigh in on your, what's happening. But some people, when migraine is over, I mean, migraine is a brain response. It's not just a headache. So you can have a prodrome, you can have an aura, you can have a headache, you can have a postdrome. And sometimes all that happens together, like it's not just, this sequence that you always see. Some people will have all of it, they'll feel like they're getting a headache, they'll get a migraine, and then they'll get an aura after the migraine starts. They'll have a visual phenomenon. But some people do have a postdrome, where they feel increased energy and they don't sleep very well. And so is it mania in the sense of a clinical diagnosis? No, they don't have 4 days of it or 7 days of it. Doesn't meet the diagnostic criteria for bipolar disorder, but you can have postdromal manic behavior. I'm sorry that she's suffering with chronic migraine as a young woman. That's tough. Let's see here. Scrolling down. What is best for panic disorder or migraine, CBT or ACT? Well, there's more data on CBT than ACT for panic disorder, but ACT is interesting. But for panic, I kind of like certain CBT as well as exposure therapy. It depends, what is provoking panic. Some people have a lot of interoceptive awareness, and they have to learn to kind of tolerate an internal state. I think one of the better things for panic is just learning what to do when you have a panic attack. And for some people who have panic with increased heart rate, I will provoke panic in my office. I'll have them run in place up and down the steps. They increase their heart rate. Oh my God, I'm having a panic attack. And you work with them. This is time limited. Panic attacks really last about 8 minutes. And unless you panic over the panic, unless you go, oh my God, oh my God, oh my God. And so teaching people how, and they call it panic for a reason. It is a very, very powerful feeling. So you can't minimize it and say, oh, it's nothing, but knowing that it's time limited, it goes up when it's at its worst, it starts to come down. When you're at your worst, it's almost over. And that's kind of a cognitive treatment and a cognitive protocol for panic that I think is really effective. Thanks for your question. Let's see here. Are there different treatments for chronic migraine as opposed to less frequent? Have you seen patients go from chronic migraine to having headache-free time? Yes. Most of our treatments for a chronic migraine and episodic migraine are somewhat similar. It is interesting that, I've seen many people go from chronic migraine to episodic migraine. If you look at the clinical trials on the monoclonal antibodies, there's a significant number of people that have done that. If you look at the research studies, or the older studies, where they had preventative drugs plus a behavioral intervention, many of those patients went from chronic to episodic, a pretty good number. The hardest that I find is it's not just chronic, it's daily and constant. And I think that's kind of a different disorder sometimes. So I find it harder to get people who have this daily constant headache back down to a either any free time or it would be great to get them back into episodic. But yes, many people do get headache-free time. But the harder thing, which you might be talking about, is from daily constant headache to having some free, headache-free times. And once that happens, it's easier to get back to episodic. So if you have a daily constant head pain, and then you get a little bit of a break in the action, regardless of the treatments that you have, that is a good sign that you might kind of backtrack, into episodic. Let's see here. Is treatment in children the same for migraines and anxiety? Is treatment in children the same? Migraine and medication for migraines. I guess you're talking about migraine and anxiety together. I mean, I haven't seen the monoclonal antibody data in kids, but the drug data for children is mixed. There's some very good data for migraine, and some of those kids had anxiety disorders where you have a pharmacologic treatment plus a behavioral treatment. And when you add the behavioral treatment to the pharmacologic treatment, these kids do significantly better. So I think for kids and migraine, it's really helpful to have some kind of behavioral treatment. For anxiety disorders in kids, it depends on, how old the kid is and the type of anxiety and how severe it is. But, the most effective long-term treatment for anxiety disorder in kids and in adults are the behavioral treatments, the CBT treatments, other behavioral types of anxiety treatments, psychological treatments for anxiety. On the long haul are the most effective treatments. In the short run, the SSRIs can be very helpful with anxiety disorders in adolescents and adults, and sometimes in kids. I don't see if we have any more. Is there anything else in there? Am I missing any? Oh, here's one. How can you get around changes in sleep patterns, missed sleep, jet lag while traveling to a different country? That's a tough one for people with migraine. People try a bunch of different things. I mean, for me, that biologic rhythm stuff is important. So I would not work, then get in a plane and go. I would try to take a day before you leave and a day when you arrive to just kind of relax a bit. And I would try to get morning sun. So if you arrive at a place at 9 in the morning in Europe, let's say, I would, if it's a nice day, or even if it's not so nice, get outside, walk for an hour or two, midday, try to reset your biologic clock. Some people like to do that with melatonin. There's a variety of protocols, trying to reset a clock before you travel. I really think it's very, very important, and I didn't mention this before, that optimization of acute care, I think, is really, really important. And so if you have migraine and you have an anxiety disorder or migraine in general, and you have something that that works most of the time, and you can stop an attack with not a dramatic amount of downtime, and then you have a rescue approach if it comes back. I think that's really, optimization of acute care has been shown to be as powerful as many preventive treatments. And I think that's really important when you travel, to know that you have a plan if you get an attack. Does MS play a role in chronic migraine? I never had them until I was diagnosed with MS. I had severe panic disorder 12 years before. I was then diagnosed with migraines and MS. I don't know. I don't know the answer. I mean, it is distinctly possible. There's possibilities that that the activation, of MS might have kind of created migraine for you. There's a comorbidity between migraine and other neurologic disorders. I don't know the relationship to MS, and it's also, it's kind of a stressful diagnosis. But it's, if you never had one until you were diagnosed with MS, it's kind of interesting, and it might also possibly be related to a treatment, of MS, to see if that was provocative in any way. But the short answer is I don't know. I wish I did. Once migraines have been treated, reduced, can anxiety, fearful, and isolation tendencies be treated without therapy? Sure. I mean, there's a ton of stuff online. There's a lot of apps, a lot of relaxation strategies. There's a lot of mindfulness-based stress reduction protocols online. If you, and many people, probably more people use those successfully than see therapists. So yeah, I mean, to get yourself to understand that isolation tendencies, avoidance is very common in migraine, and certainly very common in anxiety. So to do some kind of graduated exposure to, there's many protocols online where you can decide to increase your activity level, try to do something for brief amounts of time and then go home. But I think it's very helpful for you to choose what you want to do. So if you feel isolated and you're going to do something, and you say, I'll do this until I get nervous, that doesn't work so well. But to say, I'm going to go for 30 minutes and then I'm going to leave, regardless of how I feel, but I'm going to stay for 30 minutes, that's a much better type of exposure. And you can do a lot of that on your own. And if you having a hard time, I would see a therapist. Let's see if there's, oh, okay. My migraines are mostly from the weather and sensitivity to light and noise. Is that depression? I do have major depressive disorders, generalized anxiety, sleep problems, etc. But are my triggers really depression causing migraines, or migraines causing depression? Well, all we know is that they're comorbid. I mean, it's tough to have them both, and it's so we don't know. Yes, migraines can certainly make you sad and blue and down in the dumps, and if you're prone to depression, they could be a causative agent, but we don't really know cause and effect. What we do know is a comorbidity, that there's an association between the two. The people with migraine are more likely to have depression, and it's bidirectional. People with depression are more likely to have migraine. But migraine is a brain disorder that can be triggered by many things. So it can be triggered by weather changes. It could be considered triggered by light, by noise, by stress, by physical stress, emotional stress, many different things. So it's kind of a threshold disorder. So if you have stress and light and sound, and you get under the threshold, you might develop migraine. But all we can say is there's a comorbidity. There's not it's not a causative. The only way you can say it causative is if you have a depression, you have migraine with it, the depression gets better and the migraine gets better. And that's not as common as having a comorbidity. Okay, that's it on the questions. I really appreciate your attention. You guys, migraine sufferers, have my heart. I mean, you guys are a resilient crowd. You deal with a lot. I hope this helps a little bit in your journey, and be an advocate for yourself. I really think that's so important. And let your doctors, kind of know what you know and what you feel, and attack migraine with what you need to do. And also, if you have psychiatric issues, make sure they're addressed and looked at, and hopefully that will be very helpful to you. Thanks a lot for inviting me, and I wish everybody well. Hope to see you again soon. Take care.